Welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everyone. Welcome to the Surgical Assistant Podcast. We are back here for another episode. I'm Kelly, and I have John here with me as usual. Hello, John.
Hey, Kelly. How are you? Welcome, everybody.
I'm doing well. How have you been?
I'm good. Thank you.
Yeah,
Just finished my travel assignment, so
you
now
did.
I'm moving.
I was just
It's
going
crazy.
to mention. Yeah, I was just going to mention that.
Mhm.
John's actually, we're in the same state now. You're on the
Yeah, that's true.
opposite coast as me, but we're in the same state because you just finished a kind of a lengthy multi-contract travel assignment. So congratulations on doing that. That's always a big accomplishment to finish those travel assignments and be done. And I know you've got a full plate coming up this summer, and good for you. I'm glad for you.
That's great. Yeah, the first one I want to mention is the conference. Looking forward to going to the conference, the ASA-NSAA joint conference in April in Grapevine, Texas. It's the 25th through the 26th. So the 25th is the pre-conference workshop, which will be on endovascular vein harvesting and intro, and then the other one will be on the Ross procedure, which seems pretty cool. And then we have the scientific presentations throughout the day on Saturday from starting at 8 until I think about 5. They haven't released the agenda yet, but as soon as they do, we'll bring it to you.
Yes. We're both really excited about that and just supporting our organization and also gleaning a lot from those conferences as we usually do. So yeah, we're excited about that as well. Well, our episode today is talking about anesthesia, and we felt like it was important from the first assisting standpoint to focus on anesthesia for an episode and kind of talk about the basics and what as the first assistant needs to know from the anesthesia provider's standpoint. And we did go into a history of anesthesia in our surgical history. If you haven't listened to that episode, that's really interesting, our surgical history episode. We do talk quite a bit about anesthesia and the history of anesthesia and the advent of it. Really interesting. We're going to talk really briefly about that again, but diving right in here, John, we're talking about anesthesia, and the definition of anesthesia is it's amnesia, analgesia, and muscle relaxation or paralysis of a patient to undergo the surgical procedure. One thing I do like to reiterate is that in the operating room, when we talk about team dynamics, anesthesia is the apex. A is for, in our trauma survey of a patient, we know A is for airway, so A is first. A is the apex. Without breathing, nothing else matters. So I think of it that way: is anesthesia is the top of the apex in that operating room. They can make the call technically, and they can make the call to cancel the surgery if the patient is not fit, if they deem the patient not medically fit to withstand anesthesia. Is that your understanding?
Yep, definitely. That's the way I understand it.
Yeah. So just so we're kind of clear on that, I mean, I do remember learning that in school, that anesthesia is, we don't like to say there's a boss of a room. We all have our different roles, but anesthesia is kind of, I'm really giving them the focus when that patient is in the room. I'm watching anesthesia to read and understand the well-being of the patient. We want to know how our patient is doing while under anesthesia, because they're paralyzed, they're asleep, they're out of it. So anesthesia provider obviously is monitoring everything there is to monitor about the well-being of that patient, the medical well-being. So John, hit those few points on the history of anesthesia and how it came into play in the surgery world.
Certainly. So if some of you might remember from our episode 4, we talked about the history of surgery. The first surgery done with anesthesia was October 16th, 1846 at Mass General Hospital with Dr. John Warren. He used ether for the first time. That was pretty much discovered by Morton and Long in 1843, but it wasn't actually used for surgery until 1846. They had ether parties, and they'd all eat dinner, and then they'd all huff that and fall over and stuff, and they're like, ooh, ah. But and then somebody figured out, hey, maybe this will work for anesthesia. So they used that for the first operation on, I'm blanking on the gentleman's name right now, but they removed the cyst from his neck, and he woke up. They didn't have to hold him down. Prior to that, there was no anesthesia, and people just fought and people held them down. And I mean, they tried loading them to the gills with morphine, alcohol, none of that stuff worked. At one point, there's even a drawing of a boxer knocking a patient out. They would actually have a boxer to knock the patient out. But unfortunately, we all know that doesn't work because sleep does not render you insensate to pain. And that's what we're trying to achieve with anesthesia. I think it was Oliver Wendell Holmes that coined the term anesthesia, which means without feeling or without sensation. So that would never work because just think about it. This is what I tell the patients when they go to sleep. I'm like, is there anything poking you? We don't want you laying on any knots because you can't adjust your position, because if there's something bugging you when you sleep, you could just naturally unconsciously roll over and not wake up. But you can't do that while you're under anesthesia. So if it's pressing on you, it's going to keep pressing on you. So that's why natural sleep, if that was the case, we would just make people go to sleep and then do surgery really quickly. But that doesn't work. So they figured out that ether worked. The problem was they had to use so much ether that it would soak their tissues and it would take them days to recover for it just to get enough muscle relaxant for the abdomen. And then as time progressed, they figured out that they could use tracheium, which comes from the vine of a plant in South America. They noticed that the Waodani tribes down there would use blowguns to kill their main food source, which was monkeys. And they would paralyze the monkeys, they would fall out of the tree. And then somebody found out that if you use a muscle relaxant like that and ether, you could use much less ether to achieve the same result. So that's what got us to in a stepwise fashion. Then they started researching and using more muscle relaxants and then inhaled anesthetic agents. And that brings us to what we have today. I mean, maybe people remember going to the dentist and getting nitrous oxide. That's good for a little bit, but nitrous oxide doesn't render you completely insensate. And it takes a huge MAC, or what they call the minimum alveolar concentration. It's a huge number to keep people asleep. And it doesn't really work well for muscle relaxing. And it's not good if you have air filled, like your intestines. Your intestines can blow up because the osmolar pressure pulls gas into your small intestines. So it's not a very good drug for anesthesia. It's good for the dentist, but that's about it. We have it as a backup, I think, on a lot of anesthesia machines, but they have much better inhaled anesthetics. And they're not explosive anymore like they used to be, like ether. So
Right.
that's
Thank
pretty
goodness.
much what got us to today.
Yeah. Well, yeah, that's great. That's always so interesting to hear about. And one thing, even in regards to the history of anesthesia, is the progression and our ability to have evolved into monitoring those critical parameters. I mean, back then, so they achieved anesthesia, but I mean, were they just going on a wing and a prayer because they didn't have the modern day ability that we have to monitor those critical patient parameters such as ventilation, oxygenation, perfusion, and temperature. So
Right, correct. Yeah.
because we owe the safety of modern anesthesia to the fact that we can monitor those patient parameters, right? I don't know I wonder what they could monitor effectively and accurately back then. I
I
guess
think
they
they
could
just
tell if
put
the
them to
patient
sleep
was
and
still
hope they wake.
breathing. I
Yeah,
mean,
if they could. Yeah, but they probably just hope they wake up after the surgery.
right.
But today, I mean, there's people that are nervous, relatives or friends, when they tell me they're afraid to have surgery, they're afraid to go under general anesthesia because of all the stories they heard. And those stories are 20, 30 years old because anesthesia has gotten so much better. The drugs are so much better. We have so many more monitoring instruments that we can use, like the
Yes.
Biz monitor that will let us know how deep your anesthesia is. And as opposed to, I remember when I was in school back in the 90s, we had a nurse anesthetist come in and give us our anesthesia lecture. And when he started, they didn't have a lot of those automated blood pressure cuffs. I mean, he used to just feel the temporal pulse to give him an idea on how well the patient was perfusing, whether it was a strong
Wow.
pulse, a weak pulse, whether it was fast or slow. And that was just, he was still dropping ether at the time too, but he would just touch the temporal artery and that would tell him a good idea of how the patient was. So yeah, it's come a long, long way and it's safer than it's ever been. And it's only going to continue to get safer.
Yes, yes, and thank goodness for that. So yeah, if you've been in the operating room and you're like me, if I'm not busy scrubbed into the case or I'm at a slow point in my day, I like to go up there with anesthesia and when I can and kind of just stand and look at
Hmm.
their monitors and look at what they're looking at on those monitors. It's fascinating and definitely above my scope of education and knowledge, but I just always find it so interesting and can get a little nugget of knowledge here and there on what they're looking at and from their perspective. And speaking of their perspective, we want to kind of understand briefly that ASA physical classification assignment that they do assign these patients. We're not assigning this to the patient. And we're going to talk about in just a minute that pre-op patient evaluation that anesthesia does. And based on that is where they assign these ASA. This is in our timeout. When we give a timeout, we state the patient's ASA. Guys, this is just for us to know it's a risk stratification score, essentially, wording it basically. So we know an ASA 1 is a normal, healthy patient. A 2 is a patient with mild systemic disease. A 3 is with severe systemic disease. An ASA 4 is going to be that systemic disease that it's a constant threat to life. So, you're talking about kidney, end-stage renal failure, any kind of cardiac, most cardiac issues, those kind of things. So a 4 is we're kind of getting, 3 is, to look out for. So a 5, moving on, they're not expected to live unless they have this surgery. So it's a 5 is a life-saving surgery, and a 6 is kind of a moot point in most of our daily work lives. But a 6 would be typically a brain dead organ procurement patient. And then that E, so if you hear ASA class 3E, we know that surgery is emergent. So it is an emergent surgery. It's not an elective case. So just something for you to know as the first assistant, kind of how they're coming up with those scores, and it kind of in a very brief nutshell kind of way let you know how medically sick your patient is. Would you agree with that, John?
Yes, I definitely would. I think it's a great thing to know at least the basic parameters of, like you said, we don't have any involvement in that, but it just, when you hear that, it should kind of just stick in your mind as opposed to a brief picture of the health of the patient. So, and one interesting fact I found out that I learned through doing research is that, like you said, ASA class 1 is a normal, healthy patient, no issues. But if they're a smoker, it automatically makes them an ASA class 2. And then the higher the number, the more sick the patient is. And I believe that an ASA like class 5 is a 5E is probably one of the worst you can get. And even then, there's a 50% chance that they might not make it even with surgery. I wouldn't say 50%, but they will die with or without surgery. But then even if they have surgery, it's not guaranteed that they'll survive either, because they're metabolically very sick or they have huge comorbidities like CHF and other deals that just mess with their ability to metabolize and deal with anesthesia. So,
right. Yeah. So, and I do want to just kind of throw this in here too, that you will already know this as the first assistant. If you've looked at the H&P, if you've read your patient's H&P,
yes,
like in our history and physical episode, you will probably have a good idea of what ASA, and it's not going to be a surprise to you, right? And that's what we want. We don't want any surprises as the first assistant. We want to know as much as we can. But again, we're talking about anesthesia this episode, and so we're kind of learning from that anesthesia provider's standpoint what they're looking at. So in their pre-op evaluation, they're looking at the patient's fasting status. They're assessing that airway, in which they do assign a Mallampati score, where they look at the inside of the mouth, and they're looking at what anatomy they can see in the mouth, and that gives them an idea of if they're going to have a difficult intubation. They're looking at the uvula and the hard and soft palate and the vocal cords and that kind of thing. And so if you've ever had surgery and they tell you just to open your mouth wide and they're just looking in your mouth, that's all they're doing, is they're making a quick assessment of how difficult is it going to be to put a laryngoscope blade in this patient and get a tube down. So they're doing their systemic physical assessment. They're focusing primarily on respiratory, cardiac, hepatic, and renal systems. They're looking at their past medical history, their medications and dosages, past surgeries, and especially reactions to anesthesia. That's going to be one of their top priority questions to ask is, have you ever had any reactions to anesthesia? Have you ever had any difficulties or problems with anesthesia in the past? That's a huge one. We're going to identify allergies and reactions in those allergic situations. And last but not least, they're going to document that history of tobacco use, alcohol, illicit drugs, alternative medicines, homeopathic. Even we know that even like herbal supplements and those kind of things can affect us systemically and be important factors when we're having surgery. So all of this information they're gathering and they're making these assessments, trying to assign that ASA and figure out how much of a risk this patient is going to be while they're asleep. Do you have anything to
Yes,
say to
that's
that,
true.
John?
And
Anything, all that? Again, that's all. Most of that information should be able to be found in the patient's chart. So you're as the first assistant, you are privy to that information as well.
yeah,
And if it
or at
makes you
least we
feel
should
better
be. I mean,
to,
I don't want to get off
yeah,
on a, yeah, I
no.
don't want to get off on
If
a
you want
tangent
to,
or a soapbox here, but you should be reading the H&P because that gives you all the information that you need. And a lot of times other people in the room aren't aware of that because they don't avail themselves of the H&P. I had it happen my last week on that assignment that there was more to the surgery than what was posted on the board. And I went and got all the other stuff, and the people are in the room, what's all that for? And I'm like, oh, well, we're doing this too. Oh, no, it's only booked as a ventral hernia repair. And I'm like, well, I read the H&P, and it says it's also bilateral inguinal hernia repair as well.
Mhm.
So, and they're like, and then they went and looked at the consent, and sure enough, that's what the consent said. But you don't want to find that stuff out at the last minute because it makes everything very hectic while the patient's coming in the room and going to sleep. So, yeah, the earlier
Again,
you can
going
do
back
that.
to, yeah,
And
going back to being that above average first
mhm,
assistant. We want to shoot for above average, guys. Above average all the time.
mhm,
Know what the surgeon knows going into that operation as much as you
yes.
can. I cannot
And
emphasize that enough. Yeah.
we
Yeah.
understand that not every place gives you access to Epic, whether it's read only or whatever. And some nurses don't want you looking in the chart. They just don't. Maybe it's me as a traveler, but I always tell them, hey, listen, this is why I need to do this. Do you mind if I look over your shoulder? Do you mind if I get in there real quick? I don't do it when they're doing their charting. I try to find a quiet time when nothing's going on so I can review it. I do a quick look at the CT scan if that's in there. So it
Yeah.
behooves you to do that. That's my new
Yes, it
favorite word, by
does.
the way, behoove. So,
Behoove. That's a good one.
yeah,
So
if you listen to the Professional Resources podcast, I say that a lot in that podcast.
I need to listen. That one just dropped. I need to go back and listen to it. So yes, and we're going to interject that on these podcasts. I mean, we try to follow an
Mhm.
outline, but we are going to also interject things that we just want to encourage the listener. We want to encourage you, whether you're learning to be a first assistant, you're a new first assistant, or you're a veteran first assistant who maybe it's easy to get complacent. It's easy to just kind of go through your day and forget, but what things are important. But just shooting to be that above average first assistant is it's utmost on and I am not perfect. I do not hit it every day at work, guys. I don't. I'll be the first one to tell you that. But gosh, just being ready and being ready for what can happen. And again, knowing what the surgeon knows. And a lot of times, John, we know what the surgeon doesn't know. That's when it comes in
That
really,
can be true too.
really
Yes.
handy is when you've done your homework
Yep.
and you give some
Hmm.
information that surgeon's like, oh, is that God, listen, they have, we're focused on that one patient. They have a plethora of patients. They have a
Mm,
patient list in that hospital that they're following. Be their right hand, guys. Be their second hand of eyes and ears
true.
and and it's do your due diligence in knowing the information about that patient and not that it's just some Joe off the street coming in to have surgery. It's going to be a routine day. I mean, let's not assume that. Let's know what we need to
Right.
know. And I've had it happen many times where I've known something about the patient
Hmm.
that the surgeon didn't know because of doing my homework. And
Right. Right. And you brought up something just a minute ago that I think is important. And I know we've said it before, but I need to stress this. Kelly and I looked around. There were no resources really for surgical assistants. And I couldn't find any podcast directed at surgical assistants. So we decided to start one. And by starting one, that does not mean that Kelly and I are the best surgical assistants in the world, that we know it all and that we're so good we can put a podcast on and teach everybody else. That's not the
mm,
case. I am constantly learning. I am not the best, but I've also learned through traveling that I pick up a lot of these little pointers along the way. And if this is aimed at a brand new first assistant, or maybe it's a veteran first assistant, but they've been at one hospital their entire career, and if you're not exposed to these things, this is just one more tool to put in your tool bag. That's it. Maybe I saw something that you didn't, or we hope you'll write into us and tell us if you know something that we don't, and we can add it, because we're just trying to get better. We're trying to set the standard and be the best that we can be for that patient, for the team, and for the surgeon. That's all. We're just presenting the
Yes.
information we have. Take it or leave it. It's a smorgasbord. Take what you want and leave the rest. We're not saying we know everything and we can teach you everything. That's not it. That's not why we're doing this. We're just giving you what we learned, and do with it what you will.
Yes.
So
And obviously you can tell by our podcast that we're excited to share with we're excited to share what we know and what we're learning along the way doing this podcast. I needed refreshing on my anesthesia nuts and bolts. So this was exciting for me to dive in and open my books and I interviewed some CRNAs at work and got some information that I needed for this podcast. That's fun for me. I mean, and I've learned things and got refreshed on things that I needed to also, John. So it's a win-win all the way around.
Yeah.
So, okay, let's see. Moving on.
Yep.
We've just talked about the anesthesia pre-op evaluation, everything that they're looking at. So now we're going to move into the operating room, and I do want to. I'm kind of jumping ahead here. When we move into when that patient rolls into the operating room, we want to our focus then is on that patient. Sometimes we're still opening items, hopefully not, but I might still be doing some last minute preparations, just getting everything in my room just so, because that's the way I am. I want it just a certain way. When that patient rolls into the room, the patient is the star. That's our focus. We're focused on the patient. A lot of times I like to play music while we're setting up. I mute that music or I pause it. I turn the music off. It's all about the patient then. So we do that anesthesia timeout when they come in the room. We again affirm our patient. We use those patient identifiers. We hear it from the patient's mouth, what they're having done, what the name of the surgeon that's doing it. Really confirm that marking, the laterality marking, and all those good things. And so then we move over onto the bed. So now it's time for getting ready for that induction of anesthesia. I do want to pop in here and talk about rapid sequence induction. Do you want to talk about this for a minute, John, and just tell us why we would be doing rapid sequence induction and what that involves?
Sure. Rapid sequence induction, the way I understand it, it's done on patients, emergent patients, patients when you don't necessarily know their PO status. Maybe they've come in through the ER, or maybe it's a trauma patient or whatever, and you're not really sure if their gastric contents are emptied, because people coming to surgery, they get optimized for surgery. If it's an outpatient surgery, they're told to fast 8 to 12 to 24 hours before the surgery, depending on what they're having done, so that their stomach is empty and they're not producing a lot of secretions. Whatever essential medications they need to take, they're told to take with just a sip of water, because anesthesia can make you nauseous and you don't want to vomit and then aspirate. So typically an RSI, a rapid sequence induction, deals with using a quick-acting induction agent such as propofol or etomidate, and typically in a rapid sequence induction, the way I understand it, the classic is succinylcholine, which can present its own problems depending on what type of patient, and we'll get into that later. And always it involves cricoid pressure, because you're unsure of the PO status of the patient. So cricoid pressure, I think it's called the Selleck maneuver, and where you push down right on the cricopharyngeal notch there, and it compresses the esophagus against the spine. And there's some controversy of whether it actually works or not, but this is what I've always been taught. So if they ask me to do it, I do it. And then they're quickly put to sleep and intubated. And then once they're intubated, you can let off with the cricoid pressure once they're confirmed to be in the trachea and the balloon is up, because now the airway is protected and you can let go of that cricoid pressure. So that's typically the way I understand an RSI. And EMS will do an RSI in the field, although it's not ideal. When I was in paramedic school, they didn't like the idea of doing an RSI in certain situations, because if you lose that airway, then you've lost it. But now we have supraglottic airways, which are a bailout. But I'm not going down that rabbit hole. So that's typically what an RSI is in the operating room.
Okay. So yeah, if the anesthesiologist or the anesthesia provider asks you to, or a lot of times they'll tell the patient in a RSI that's having rapid sequence induction, they'll tell the patient, you may feel a little pressure on your neck as you're going to sleep. I always take that as my cue to go ahead and apply that cricoid. So we know, just a little nugget here, anatomical nugget, we know that cricoid cartilage is the only one with a full ring around it. So therefore, when you press down on it, it theoretically compresses the esophagus, like John just said. and prevents any regurg coming back up. So, yeah, if the anesthesia provider tells the patient, you're going to feel a little pressure on your neck, I just take that as my cue to go ahead and apply that pressure. You don't want to take off that pressure. I'm always watching my anesthesia closely and waiting for them to tell me it's okay to release the pressure there. So, just a little quick hit on rapid sequence induction, why we use it, what it is. Cricoid pressure is also utilized during intubation. As you can see, if you've ever used a glide scope, if your provider has ever used a glide scope, and you can see on the video the anatomy, and you can see the effect of your cricoid pressure and how it moves those cords over, and they can see it. So sometimes we're doing cricoid pressure under their direction. They'll tell you exactly what area to push, how far, like whether we need to deviate it one way or the other. That's just to help their visualization. So we want to separate those two things right there. So the cricoid pressure in that scenario would mainly be to manipulate that anatomy so that they can have a better view of where they're guiding that P-tube into. So two different things there. Make sure you know how to do cricoid pressure appropriately and accurately. I have never asked anybody to show me something or ask them a question about something and had them say, that's a dumb question, shame on you for asking it. Ask questions, guys. If you are not sure, do the patient a favor first and foremost and just ask the question, even if it's in the moment. I mean, ask it, and they will, but you should know how to do cricoid pressure, and so we want to encourage you to know how to do that and know when it's indicated. Let's see, I'm going to skip over regional anesthesia right now, John. I know that's next on our list, but I'm going to skip over that and save that for a minute. We
Sure.
want to talk about the LMA, the laryngeal mask airway, is another form of ventilating the patient during surgery. And what do you know about the LMA? I actually had to ask a couple of questions to one of my providers on the LMA. I wanted to clarify what the specific indications were and what they kind of looked at on patients to do an LMA. So, what do you understand about an LMA?
Well, it's interesting because I remember when LMAs first came into use and they were all non-disposable and they used to re-sterilize them. So that's how old I am. But it's what's called a supraglottic airway, which means it sits just above the glottis and above the cords. So you aren't protecting the airway as much. The way it was initially explained to me is it's a way to keep the patient asleep without intubating the patient and getting into all the other issues they can have with intubation if it's not a deep invasive procedure. And typically the way it was done was the patient would breathe on their own. They never used the ventilator because the ventilator can cause increase in pressure, airway pressure, and that can squeak around the cuff and go down into the belly and cause them to vomit. But I see a lot of people, and I guess that's changed, or maybe it's new studies have come out, I don't know, but I do see a lot of patients get hooked up to the ventilator, and maybe their pressures are down and their minute volumes, their tidal volumes are less, but they do hook them up to a ventilator now. But the way I've seen it done in the past initially was they were breathing on their own, anesthetic gas was on, so as they would rise and start becoming aware, they would breathe faster and then they would go down, and it was kind of a sawtooth pattern of anesthesia. And the other reason for an LMA is it's a good bailout. If you can't get the patient intubated, you could at least get something down there, hopefully. So now I see the original LMA had an inflatable cuff, and some of them still do, but now there's something called the iGel that a lot of places are using, and it's like a gel cuff that you don't inflate, and it just kind of conforms to their supraglottic airway. But that's all I know
Nice.
about an LMA.
Nice. You did good off the cuff. I really did have to. I don't think I could have explained that well, not having had the
That's just because I'm
refresher that I
old
had with my
and I've seen
wonderful.
it done.
Yeah, it's just because you're old. You've been around too long. My
Yep.
CRNA buddy at work. I'm sorry, he's an anesthesia provider. He is actually an AA, but the LMA. So I was asking him specific. So
hmm
they look. It is considered minimally invasive, so we want to think of it like that.
hmm
It's minimally invasive, and it's less invasive than intubation, which is what you just said, one of the things you just said. So it's ideal when they can do it. So one of the things they look at is the length of procedure. So he said typically less than 2 hours. If you're thinking the surgery is going to be less than 2 hours, that makes the patient a candidate for an LMA. They would not do it in obesity. If the patient is obese, they're not going to
Mm,
consider an LMA. Didn't ask him exactly why. I'm assuming that it's because of the redundant tissue.
mhm.
Kind of would just be, and it's better to have that just complete control of the airway in an obese patient. And also, no paralysis is going to be needed. So, a lot of times you'll see what are some of the procedures we see in LMA used in breast biopsies, breast lumpectomies, um, where we don't want the patient, even if it's a sentinel node biopsy, we don't want the patient. We talked about in our breast episode how we don't want the patient paralyzed because we want to know about those nerves right there that are in that area. So, an LMA is a good, that's just one example that in those breast surgeries, that's a good indication for an LMA. Typically, that lumpectomy doesn't take very long. So, less than 2 hours. And you're right, the patient, yes, the patient is breathing on their own, and it's just kind of supporting the patient's own breathing. But they are fully asleep. That's considered general anesthesia still. So that's a great, I'm pretty sure I've had an LMA on one surgery that I've had. So I didn't have a sore throat afterwards. So that was
Okay.
nice. Okay.
Hmm.
So we wanted to talk about that really quick. Aaron told me, he said, just think of it as a very large oral airway. And I was like, okay, well, that's one thing, when they
Hmm.
put the oral airway in at the end. He said, just think of it as a very large oral airway. It's just kind of expanding the tissue of supraglottis and opening it up so the patient is breathing on their own. They don't need to be paralyzed, and it's going to be a short, think under about 2 hours
Hmm.
procedure. So, just some information to put in your back pocket. We're going to talk
One
about,
thing, let me just
go
mention this.
ahead.
Let me just mention this, Kelly. The one thing to keep in mind with an LMA also is that it's not a definitive airway, so they can still have a laryngospasm because it sits above the cords.
Mhm.
So that's a reason why they don't use it for a lot of different procedures as well. So, and then they also have intubating LMAs too that actually have a channel that you can actually intubate through should you need to because
I
it's
did
sitting
not
right
know
there
that.
at the
Uh
glottis.
huh.
So it's a
I
yep.
did not
I
know
don't see them too
that.
much anymore. Not a lot of people use them, but initially they a lot of places had used those. So, but
Well,
I think we're
I've
moving
certainly
on to
been in
phases of
cases,
anesthesia.
yeah, I think we've all been in cases where LMA, they can start with an LMA, but if they have to convert to full intubation, they can. And I've certainly seen that for whatever reason. Like if we decide,
Hmm.
oh, the patient needs to be paralyzed or you run into any kind of problem, they can convert to and just come in and go ahead and fully intubate the patient. So I guess that's just a safe thing to start with, knowing that they can always progress to that full intubation. But I didn't know that there was one that they could intubate through.
Hmm.
That's interesting.
Yep. And then since you
Okay, let's talk.
mentioned breast biopsies, I'll bring it up.
Uh huh. Yeah.
Oh, since you mentioned breast biopsies, I'll bring it up. This is where knowing your surgeon, knowing your anesthesia provider, and knowing your patient come in handy because I've been in several cases when, let's say, it's a big breast biopsy or maybe it's a re-excision for margins and they plan on doing it with an LMA and local anesthetic. Or let's say it's booked as a MAC, which is moderate anesthesia care, where they give some sedation and they give local anesthetic. 9 times out of 10, you cannot give enough of a field block that those patients don't move around. And you don't want a patient moving and trying to rip their arm up and grab stuff while they're in a twilight. Especially if they've given certain medicines, they're not fully awake and they can't control what they're doing. So I always ask the anesthesia, I was like, hey, can you consider an LMA in this patient? And it's worked for me several times because I've done cases where the patient's fighting the whole time and it takes longer to do the procedure and it interrupts and it's not safe for the patient either. So I'll just throw that out there. I'll say, hey, can we do this with an LMA? And then that's all I ask and let the anesthesia provider do what they will. So just a little
That's an
caveat.
excellent point. Yeah, that's an excellent point. And you're obviously it's not out of line to ask that and to say that at all. Because sometimes the anesthesia, they
Sure.
don't know what we're fighting. And I know exactly what you mean when that patient's wiggling and moving and
Hmm.
especially like in ports or hemodialysis catheter placements, anything like that, that they're moving and it is taking us longer to do. They may not be aware of how it's
Hmm.
affecting what we're doing. And to say that is completely acceptable to do that. So that's a great point, John.
Hmm.
So our going back to our general anesthesia, the three phases are induction, maintenance, and emergence. So we all know what
Hmm.
induction is, the steps. They give the propofol, or that it puts them to sleep. What am I trying to say? The hypnotic. It's like a hypnotic, but
Induction agent.
propofol just,
That's just what I call
yeah,
it.
it's
I
an
just call it an
induction
induction
agent.
agent.
Yeah. So so anyway, induction is getting their airway secured by either an LMA or just a full on tube into the trachea. Maintenance is what they do during the procedure. They're maintaining their how far
Mhm.
in under anesthesia they are and all that. Emergence is going to be that waking them up, and extubation, which I will say to that is super important. When that surgery is over and you've closed, you put the last stitch in, you've put that dressing on, you've gotten the drapes down, don't leave the patient. Don't do it. Stay right there by your
Right.
patient. If you happen to
Mhm.
have a nurse or a circulator in the room that insists on being up there by their patient, that's fine too. You stand on the other side. Anesthesia can't have too much help up there during this is a critical time in this procedure, and I feel like
Mm.
it's overlooked a lot of times, and it's undervalued as a critical point in the case is this extubation time, right?
Mhm.
Again, if we've listened to music during that
Mhm.
case, we want to turn the music off. We want it to be quiet. We don't want to be having loud conversations. We want to stand there and be
Mhm.
available to anesthesia while that patient is coming out of that anesthesia. And a lot of times we're protecting the patient. They start waking up, those arms start moving and flailing and coming up to their eyes. And we just kind of want to gently bring those down and just kind of help the patient control those movements. And really, I'm focused on the patient and I'm honing in to anesthesia too. And I'm watching them to see if they're having any issues. Do they need anything? Do we need to call for an O2 tank for the transport to PACU and that kind of thing? Can you think of anything else that's really important during that time, John?
Well, the phases you brought up are very important because that is the meat and potatoes of anesthesia. I mean, that's what they do. They are balancing the patient's physiologic reactions to what we are doing to them to surgery. So, and we have a lot of medicines that'll short circuit that. So, the two most critical times for a patient is induction and emergence. And with induction, the last sense to go is hearing, and with emergence, the first sense to come back is hearing. So, it's important that the OR be calm and tranquil as much as you can. I mean, that's why Kelly mentioned turning the music off, keeping the conversation to a minimum or not loud at all. And I've seen it. I'm sure you've seen it. There'll be anesthesia providers that will just like, "Hey guys, patient's going to sleep or the patient's waking up. Can we quiet it down?" That happens more during emergence because we've all gotten in a routine, but you're right. Anesthesia has become so safe that we become complacent. But I always, whenever a patient goes to sleep and whenever they wake up, it's just a little increased pucker factor for me because that's something's going to happen. That's when it's going to happen,
Mm-hmm.
especially during induction. Because if we are making intentionally, they are making intentionally making the patient hypotensive because the act of intubation makes them hypertensive. So they want to kind of balance that out. So
Mm-hmm.
especially if it's a trauma patient, and if a patient's going to code, they're going to code right during induction, no matter what their status is. And obviously, if they're healthy and they have no problems, that's a remote possibility. But if the patient is sick and induction is the most critical time, especially if it's a trauma patient and they're hypovolemic, that is the time because they can compensate and maintain all right while they're awake. But once we take away that from them, you can lose the airway. You can lose. I had a patient, pediatric patient, that had a mediastinal tumor, and the patient was breathing just fine on his own, maintaining his own airway. But the second they paralyzed him, he lost that tone of his airway and it collapsed, and we couldn't reintubate the patient, and the patient expired. And it left a huge impression on me because I was like, how is that possible? They were breathing on their own just fine. But the size, weight, and pressure of the tumor and where it was, the patient's at that time, natural physiology was keeping the airway open. I'm sure it would have come to a time when it wasn't. But the act of anesthesia caused that patient to code. So that's why we have to really be on the ball
Yeah.
and pay attention to those times. And the anesthesia takes place in a progressive fashion. So the first muscles to be paralyzed when they use a general anesthetic are the facial muscles, neck muscles, all the way down. And the first one to go is the diaphragm. The last one to come back is the diaphragm. And that's what we're responsible for breathing. So we need to pay attention to that stuff. But
Mm-hmm.
induction is always the most critical time. And that's when I'm the most aware. And emergence is as well, especially in kids and especially in patients that use ketamine in. Emergence reactions were common because maybe they didn't give them enough benzodiazepine to counterbalance that. And people, I remember kids used to, and people used to report seeing demons and they would freak out because it's a dissociative anesthetic. So it's like a hallucinogen. So anything that's in the unconscious that's not dealt with is going to come through because the ego is not blocking that. But
Mm-hmm.
I just think that two most critical times for you to be available to anesthesia are induction and emergence. And some
Mm-hmm.
places that could be different. The nurse will kind of let you know, they'll push you out of the way if at that facility, and you'll know if the nurse needs to be there. Sometimes the nurses like to be there for induction, but a lot of times it's us, and they rely on us because they have their own stuff to do. So whatever I'm doing, the second that patient rolls in the room, I introduce myself, I get a warm blanket, and I stay there with anesthesia, unless of
Mm-hmm.
course I'm told not to, or if another doctor comes in or whatever. But you got to play it by ear. But yeah, those are the most critical times. And the maintenance phase is also, it's like cruise control, but you got to realize anything can, it's like flying. It's safe until it's not. So, but it's become so safe now, and the deaths during anesthesia are rare and they're uncommon, thank God. So,
Right. Well, thank you for sharing that story, John. That is just a great reminder of
yeah, certainly.
how important it is. And that's a real life reminder. I mean, what a tragic thing to have happened, but it's just it reminds us that
Yeah.
we shouldn't be taking for granted anything that we're doing back there, but particularly related to anesthesia. So, and those sounds like you and I have much of the same routine when it comes to assisting anesthesia.
Hmm.
There are some ancillary things we want to, some ancillary support things that we do want to talk about with anesthesia is, of course, we're looking at the fact and considering the fact that while a patient is under anesthesia, our bodies do not have the ability to regulate our temperature. So, this is why we're putting those bear hugger warmers on or the hot dog, whatever warming device you have at your hospital. We do want to keep that patient warm. Our bodies literally do not have the ability to regulate our temperature, and we know that normothermia during surgery is pertinent to a lot of things, our bleeding potential, our healing potential. It affects that body temperature affects a lot of things systemically. And so we do want to keep that regulated, and our anesthesia provider is monitoring that temperature, the patient's temp during the case as well. A lot of times, if I'm hot in the case or it feels hot in the room to me, the first thing I ask anesthesia is how is the patient's temperature before I ask the nurse to cool the room, to turn the thermostat down or check and see
Hmm.
what it says. Maybe it's just me. I ask anesthesia how the patient is doing with their temperature. And also the IV situation. A lot of times we do want to have that second IV in. This helps for a couple of reasons. I mean, we're looking at fluid management. That's a whole fluid management is a entire uh, book that we could get off into. We could go down a lot of rabbit holes with fluid management, but we know that we lose a lot of fluid
Hmm.
during surgery. And so those IVs, first of all, they want to have just a backup. It's as simple as just having a backup. If the one IV goes down, now they've got a second IV. But
Hmm.
also it's emergent access if the one stops working. Dual IV access also is used to replenish fluid volume postoperatively so that they've got two IVs postoperatively if that patient needs more fluids. Um, so we want that to be an 18 or 20 gauge in that second IV for sure. A lot of times, if our pre-op nurses are placing those IVs, they don't really think of those large bore IVs like we like to have. But yeah, we like to place the
Hmm.
18s or 20s for sure, if possible, in the second IV. And then we're going to move on. If you don't have anything to add as far as the temperature, keeping the patient warm, and that IV situation, we're going to talk about positioning. I think this is going to be, we're going to have a few things to talk about with positioning um,
Yep.
here.
I just have something to mention on that. Like you mentioned now, in the recent times, they've come to learn that normothermia is one of the most important things for the surgical patient, especially the trauma patient. I mean, keeping the patients warm. The trauma patients come in, what's the first thing we do? We strip them down because we have to check them for injuries and things. But now we immediately cover them up and warm them up because hypothermia is part of the lethal triad. So the lethal triad is coagulopathy, hypothermia, and acidosis. So if we can take away a leg of that critical triad, then that makes them much safer and less chance that anything can happen because if they get hypothermic, they get coagulopathic. So the close to normal you can maintain their body temperature, the better. And it also affects healing. So I think that's incredibly important. So, and when it comes to the second IV, excuse me, my nose is itching. So when it comes to the second IV, if it's a laparoscopic procedure and the patient's going to have their arms tucked, that's the first thing I ask before I tuck the arms. Is it okay to tuck the arms? Do you want another IV here? Depending on the case and how long it's going to last, some providers are like, nope, you're good, you can tuck it. Or like, oh, maybe they'll thank you for reminding them. Or like, no, I plan on putting an IV in there, so don't tuck that. So I'll go to the other side that's got an IV and I'll tuck it. And also choice of IV sites is important too, because they always go for the antecubital. Obviously, the patient needs an IV. You want to go where you have the highest likely chance of getting an IV. But, especially if they come in through the ER, you can guarantee it's going to be in the wrong place. So a lot of times the anesthesia providers will want to put one in a better, more advantageous spot. But yeah, that's just about what I've got on that. But yeah, positioning does affect anesthesia as well. So
Yeah, and that's that's great that you even mentioned the monitors. We'll start off with positioning. The first thing with positioning is we want to make sure that our positioning
mm-hmm,
is not interfering with any of their monitors, IVs included. I mean, obviously, when we tuck the arm, when we tuck that IV arm, we want to look up and make sure that IV is still running. We want to make sure that art line is still working when we've tucked those arms.
mm-hmm,
So, just that simple, basic positioning rule is good to know. But specifically, when we're positioning patients where it's going to put pressure on the airway, put pressure on the chest or the abdomen, we want to consider. Come into mind, steep Trendelenburg is a big one, as well as lateral and
mm-hmm,
prone. So we want to
mm-hmm,
talk just a little bit about how those positions can affect anesthesia, affect the airway, and how difficult it is, maybe some problems that it presents for the anesthesia provider when the patients are in these positions. And if you add
mm-hmm.
on weight, obesity, that's just an
Yeah,
extra added headache for anesthesia to deal with. It just is. I mean, it,
it's
you've
an
got to
added
look at
risk.
the patient's habitus and how much they weigh. I mean, these
Mm-hmm,
things affect literally the care and maintaining that the airway and the air exchange for these patients. So steep
mm-hmm,
Trendelenburg, I I remember learning that in steep Trendelenburg that we were to take the patient out of steep Trendelenburg after a certain number of hours to give them a break, but I quite frankly do not see that being a priority these days. Do you? Has anything changed with that, or does anesthesia just not insist on it, or
Well, in my
I don't
experience, I've
know.
seen, yeah, in my experience, the surgeon's only concerned with the surgeon, the field they have to see. So obviously in pelvic procedures, we want to see, we want the guts out of the way. So we put them in steep Trendelenburg. But that becomes an issue for overweight patients because now you have all that extra weight and their lung excursion it isn't like it used to be. So they cannot take as deep a breath and they have to push against all that weight. So therefore their end tidal pressures go up, their airway pressures go up. And the patients a lot of times do not tolerate that well at all. And a lot of times you will hear anesthesia fight back. Like if you put them, a lot of docs want 28 to 30 degrees of Trendelenburg for a robotic hyst or a low anterior resection or something when they're doing part of their dissection. So if they put them in that position, which is another reason why it goes to another video, but when we do those cases, I always do a tilt test first. After the patient's completely positioned and in place, I want to make sure that their body doesn't shift, but then I want to make sure that anesthesia is happy with their peak airway pressures as well. Because if they're too high for too long, anesthesia will not let that happen. So you might have to get away with less Trendelenburg. So, but
So most of the time it is a laparoscopic or robotic assisted
mm-hmm,
procedure there. So you can also lower the intra-abdominal pressure as well. But no, I have
yep,
absolutely been in cases where anesthesia said, this patient's not tolerating this. Like we got to
mm-hmm,
come out of this
exactly.
altogether. But my point a few moments ago was that I learned that after, I don't know if it was 3 or 4 hours, that if they've been in that steep Trendelenburg, that we need to stop the case, take them out of
Mm.
steep Trendelenburg for 15 minutes, give them a 15-minute break before continuing. And my point, I think, was that I
Hmm.
just don't ever see anybody do that.
I don't
That's,
see it either. I haven't seen that done.
mm-hmm. But
But
anyway, just
not to say it
knowing,
doesn't happen.
right, just knowing that, being aware that all of these factors, having that intra-abdominal pressure as it is with the um, peritoneal insufflation, even when the patient's supine, we've
Mm-hmm,
already given a challenge there because we're pressing up against the diaphragm and limiting that lung space.
mm-hmm,
And then when you go on steep Trendelenburg, it's just making pouring salt in the wound, if you will. This, by the
mm-hmm,
same token, lateral and prone are both presenting the same kind of challenges to anesthesia. And I think the point here is knowing that it's really, I feel like, and John, please speak to this, but I feel like the main point of all this is that it's potentially compromising that patent airway, number one, in prone
Mm-hmm.
and lateral, but then also
Mm-hmm.
inhibiting the patient's air exchange and pressures and all that. So just knowing that that's a challenge for
Mm-hmm.
your anesthesia provider so that you can be extra in tune to them when you're in these positions is the main thing I feel like we need to be aware of, and knowing how to correct, especially like lowering that intra-abdominal pressure, taking them a few degrees
Mm-hmm.
out of Trendelenburg and seeing if we can do the operation like that. Just having these kind of suggestions um, to correct the problem or
Oh,
help correct
exactly.
the problem. Yeah.
Yeah, position is a huge effect on patient's anesthesia because, like you said, depending on the patient, also depending on the surgery. If it's a thoracic surgery, whether it's open or thoracoscopic, now you're only ventilating the patient on one lung, and it's usually the dependent lung. It's usually the one that's their affected lung is going to be sticking up, so you can get to it, and then all that weight's coming down on there. And now if you're using any kind of pressure or you're taking away the natural negative pressure of the chest, you're compressing those main vessels, the great vessels in the mediastinum. So one thing that anesthesia does is it affects preload, which is mean the available blood coming to the heart to be pumped out, which is why I was always taught that the SCD pumps should be on and functioning before the patient goes to sleep, and they should stay on until they're extubated. I don't see that at a lot of places anymore. I mean, I put them on and start them as soon as I can, but the nurse, the first thing they're doing is jerking them off the patient, unhooking them as soon as they undrape the patient while the patient's still asleep. And I don't do that personally. I leave them on because you're affecting the patient's preload, and that venous return is necessary to help them adequately, their cardiac physiology adequately helps their cardiac physiology. So, but position has a huge effect on anesthesia. So
Yeah, I'm so glad you
that's just one
mentioned the
little
SCDs because
positioning.
we didn't even mention that. I
Hmm.
mean, we know that's in our routine, but just how you just
Right,
described that is a perfect example of what's going on
right.
physiologically with our patients. Things that you don't,
Yeah.
guys, you don't have to
They're not
know
just to
the
prevent,
exact science. Exactly. It's not just a massage on
right,
the legs like we tell the patient. It's like a
right.
really big deal.
Or to
And
prevent
is
DVTs. I mean, preventing
right.
DVTs is important, but there's another reason, a physiologic reason why they're on as
Yes.
well.
Mm-hmm. Yes. And that's a big deal, knowing that there's a lot going on there that we don't necessarily, again, like you don't have to understand it like a physician does, but just knowing that it is there and why you're doing what you're doing, again, that it is a big deal. And I'm one of those too, John. I can't, when people come rip those things off, but I stick them, I just kind of hook them back up until we're extubated. But so just knowing that how that's affecting, and again, ask questions, ask not in the moment necessarily, but ask your people why are we
Hmm.
so concerned about the patient's position and how does it affect the patient? And you'll get answers, and also do your due diligence in reading up on these things and knowing. But
Hmm.
for the intents and purposes of this podcast, we just want to talk about the fact that you need to know that it does affect your patient, and
Hmm.
to follow anesthesia's lead on these things, and to know how to safely position your patient for all of these things. Again, like John mentioned earlier, I think before we started recording, about putting that strap. Don't put that chest strap on. Don't crank down on it. That makes a huge impact on your, you don't want a lot of pressure on that chest during the robotic procedures. Make sure there's not a lot of heavy cords and equipment laying on your patient's face. Ask anesthesia if they've padded the face. Remind them to do these things. I keep all the heavy stuff off my patient's chest. I don't want a bunch of laparoscopic cords and cameras curled up there on my patient's chest. That's added weight into already what they're already compromised in the position that we have them in, the fact that we've got their belly insufflated. I mean, all these little factors and details come together to potentially harm our patient. And we want to make sure that all of these things, I check with my routinely on robotic. I put my hand between that robotic elbow arm and the patient's ET tube, and I ask anesthesia to do the same from their end, like check and make sure this isn't hitting your tube. I don't want the patient's tube to get knocked out by the robot arm that I cannot see because we don't have
Right.
a clear drape, or these. I don't have to tell you all these drapes are down in our way and we can't see anything. But just being cognitive that
Hmm.
all of these things can affect anesthesia, and thinking of it in the way that what anesthesia is doing is even more important than what we're doing, because
Hmm.
without them doing what they're doing, we don't have an alive patient to work on. I mean, our patient, like if
That's
they're
true.
not breathing, if their heart's not beating, if they're not being perfused, our surgery and surgical procedure is for naught. I mean, we're
Hmm.
just not, it doesn't matter, right? So we've got to go
Yep.
back to our apex and our ABCs up there. It's super important to
And that's
consider
a
all these
good
little
point you
things.
brought up. You brought up a great point about robotic procedures. And I didn't see this until I worked in one hospital. It's called the Butler table, and it's a little table. I think they use something similar in open hearts, but it goes over the patient, hooks to the bed, and it's a little shelf. And I love it
Mm-hmm.
because it gives you a place to anchor things, but it also protects the patient's face from the robotic arms. It doesn't allow them to collide with the patient's face at all, and it gives you a place to put things. You can throw your cords off of there, but I'm a big stickler for that. I hate when I'm always paying attention to this because people just throw stuff up there, especially the robotic
Mm-hmm.
cord or the camera cord. They'll just loop it around and set it on their face, and I'm like, I make sure that that doesn't happen. But that is a big thing, is knowing that. But we tend to forget because we just see the drapes. We forget what's underneath there. We get
Right.
we get
I was taught.
complacent because we're just dealing with what we can see, and that's a great idea. Yeah.
I was taught early in my
Yep.
training, my FA training, to after we drape the patient, to ask anesthesia to put their hand over the patient's face and bump the drape and take the
Hmm.
marker and put a big X or a circle or whatever you want your mark to be, and that tells you that's the patient's
Yeah.
face right there. And so then you have a visual at least of the patient's face is right there, so you know
Hmm.
that's the area their tube is going to be
Hmm.
in.
Yep.
Any little trick you can do to help
And I will do that
keep
sometimes.
hmm to help remind you and keep the patient safe is good. Let's see, going on and talking about Sugamidex is a drug that we can use now if
Hmm.
we've finished our procedure and we're entering into emergent stage of anesthesia. Sugamidex is a drug that reverses that
Hmm.
paralytic, which they need if the patient, for whatever reason, isn't metabolizing the paralytic agent that was used. Um, they don't need to be extubated if they're still paralyzed, right? They can't do
Yeah,
that.
exactly.
So
Or maybe sometimes
Sugamidex I think,
the
has been a
surgery
great.
doesn't go as.
Yeah, go ahead, John.
No, go ahead. You can finish. Go ahead.
Yeah, no, I was just saying that Sugamidex has
Hmm.
been a great tool in their pharmaceutical tool belt to use to
Hmm.
reverse the paralytic, so that if they're not moving that diaphragm, they can't be extubated until then. So
Hmm.
usually that's not kept. Usually they have to go get that extra. But just you as the first assistant, again, knowing what that is and what it's used for. That's why they're asking for it.
Hmm.
And then we really want to kind of quick talk on some potential anesthesia emergencies that can happen with
Hmm.
laryngospasms being one, probably a lot more common than malignant hypothermia. Malignant hypothermia is the other one, which we have to stay up on and do our MH drills and all that. So we kind of all have to go through that at our different facilities. But laryngospasm is probably a lot more common. Well, it is a lot more common.
Hmm.
And do you want to talk about laryngospasm and what that is?
Yeah, sure. Airway emergencies in the operating room are dynamic events, and they happen suddenly, and they're very intense. And I know from myself, human beings don't deal with stress well. We think that we'll always rise to the occasion and do what needs to be done when it needs to be done. But the truth I've learned in my life is you're only as good as you practice. So you never raise to the level of the emergency. You always default to your lowest level of training. So that's why when this stuff is going on, I always game it out in my head ahead of time. So when I'm at the head of the bed and the patient and the anesthetist is intubating the patient, pushing the patient, inducing the patient for general anesthesia, I'm running through all these what ifs in my head. Okay, what if they can't ventilate? What are they going to need? Okay, what if they can't get a good airway view? What are they going to need? And a lot of times your good anesthesia providers will have done this and they will have the glide scope in the room already just in case, but know where that glide scope is. And before we get into that, though, let me just talk a little bit about Sugamidex. Sugamidex is recent. I first started seeing it used in about 2017, and it's a reversal agent for non-depolarizing muscle relaxers. So as muscle relaxers that we use in anesthesia, there's two types, depolarizing and non-depolarizing. And depolarizing causes the complete release of the acetylcholine across the nerve synapse, and it totally fills up the receptor sites. So no more can get through, so that is temporarily blocked, but the transmission of the electricity to the nerve is temporarily blocked across that synapse. So it can't go. So the muscle can't move, which is why when patients go to sleep with succinylcholine, you'll see them fasciculate. And succinylcholine is a good drug, but you can't use it in certain patients. Crush injuries, patients with renal issues, high potassium patients, it's just not good. So depolarizing muscle relaxers are more common, like rocuronium, vecuronium, tracerium. I mean, there's a bunch of them. Pretty much the only ones you see now are rocuronium. It's a good drug. And what that does, it's non-depolarizing. So the drug itself gets in between that synapse and fills up the receptor sites, and it stays there for a certain amount of time. But sugammadex, what that does, it's basically a sugar molecule that's got some other stuff wrapped around it, and it draws that drug out of the synapse and into the blood plasma where it can be excreted or metabolized by its normal operation. So I worked at a high volume bariatric center in Michigan, and every patient got sugammadex, and they just did so well. Sugammadex is indicated for a lot of different reasons. People get residual neuroblockade after anesthesia. Sometimes the case doesn't go as long as you think it'll go, or maybe they just gave a dose of paralytic and the doc's like, we're done. Well, you're done. I just gave more rocuronium. Because for certain patients, you need the patients completely relaxed. Like if you're doing like a Reeve Stopa or a TAR, abdominal repair, abdominal hernia repair, component separation, that kind of stuff, you need them completely relaxed. So sugammadex has become a lot more common. It's an expensive drug, but some places you need like an act of God or a dispensation from the Pope to get it. I mean, they only keep it in pharmacy, so you have to send for it if you think you'll need it, which adds a whole nother level of complexity. But I've worked at a lot of places that the anesthetists actually have it in their drug cart. So it's not a big deal, and they're allowed to use it. They're not given any kind of grief about it. And one thing we noticed working at that bariatric center was patients just did a lot better in PACU because they could breathe a lot better and deeply. So kind of calls to mind, I'm wondering how many patients weren't adequately reversed before in the past. Anyways, that's just semantics, but the other drugs we used to use prior to sugammadex were neostigmine and physostigmine. And I'm not going to get into the physiology of those, but they don't work as well. They bring with it their own problems. But sugammadex reduces all those complications by at least 40%. So it's a wonderful drug to use. It's expensive, like I said, but if you use it correctly, it can actually create money for the hospital. So, but its effectiveness in reversing deep paralysis is one of its greatest advantages. And it's got no autonomic effects. It doesn't cause bradycardia, and it doesn't increase secretions like some other drugs can. So that's that. That's just my little brief thing on sugammadex. I think it's a great drug. A lot of people do. It's wonderful. So that, but I think what we were saying in laryngospasms is slamming shut of the vocal cords. And if they extubate too soon, or sometimes some certain stimulus can cause it in the patient, which is why they don't want you touching the patient a lot during emergence or induction, because sometimes they could just slam the cords shut. So a lot of times what you'll hear before that is they'll extubate the patient, then they'll put the mask on them, and they'll listen for the patient breathing, and you can hear what's called stridor, which is a high-pitched wheezing in the upper airway. Stridor is an upper airway sound, not a lower airway sound like rales or rhonchi. So if I hear that, the first thing I'll look at the anesthesia, they recognize it, they'll grasp and make sure they have a good seal on the mask, and then I'll ask them, do you want me to squeeze the bag? Because you can break a laryngospasm with positive pressure ventilation. So sometimes they can do it themselves. They'll say, no, I got it. Or they'll grab the mask really tightly, say, hey, John, can you bag the patient? And they'll tell you what to do. But laryngospasms are an airway emergency. And if you can't break it with positive pressure, then you have to give them succinylcholine and reintubate the patient. Or at least give them succinylcholine and breathe for them. That's the only thing that's going to stop that laryngospasm. So you're not going to use something like rocuronium for that. Typically, you want a short-acting muscle relaxant, which succinylcholine is. It's got a really rapid onset, and it wears off quickly too. Whereas non-depolarizing ones have a longer action of onset, and they wear off slowly. So that's typically that is what a laryngospasm is. And then you need to have another form of airway management possible. Sometimes they might put an LMA in if they don't want to reintubate. The other thing is you always got to keep in the back of your mind that a surgical airway is always a possibility in something like that. So, basically whatever. But the more you can game this out in your head, the better off you'll be when it actually happens, and practice it as much as you can. That's why we do MH drills. That's why we do code drills and stuff like that, because everybody thinks, oh, I know exactly what to do. And you may know exactly what to do, but in that moment when that adrenaline hits, your brain turns to water and runs out your ears. I've heard it say in a lot of different situations. So I think it's important to at least have a mental map in your head of what you're going to do. Okay. Make sure you know where the glide scope is. So, but one thing I thought that Kelly and I talked about at the beginning of this, before we started recording, is we should just take you through a typical general anesthetic induction and what we do and what we're thinking about and what we like to have in the room. So did you want to start that off? Do you want me to start it off?
Yeah, no, I was just going to go over that and just talk about just being prepared for those emergencies. In your downtime, ask your provider, ask a provider. In the case of laryngospasm, like what do you need? What are some of the possibilities? And this is if you don't know. I mean, if you're new and you don't know, the primary thing we want to focus on here is just being available for your anesthesia providers. Hopefully you have a good anesthesia techs that are setting everything up for your providers back there at their stations. But I obviously, as far as all our positioning aids, we have all our positioning aids. I'm communicating any unusual positions to the patient, to the anesthesia provider. A lot of times they don't know if we're going to have to go lateral. I communicate to them if I think that my position is going to affect what they're doing up there. I communicate to them, like, we're going to have to be in this position. Even as simple as arms out, or arms going to be out or tucked, they want to know, because they want to know, are they going to have access to that IV and those other monitors? A lot of times, if the arms are going to be tucked alone, they just want a second IV for sure if the arms are going to be tucked. But yeah, knowing where the glide scope is, we don't typically have the laryngoscope, the glide scope in the room unless I feel like, or they've communicated to me, have it in the room, and then we'll get it in the room. But yeah, just looking at all the positioning aids and being there is the most important thing. Just being available to your anesthesia provider in those moments before induction and anesthesia is instigated. So those are the main things. IV, I try to make sure that our second IV, our IV materials are out, IV start kits and all that, that they have the fluids that they need. So, yeah. So those are some of the main things that I do. Of course, in the setting up of the room, I've got the SCD machine going, and I make sure we have a bear hugger and all those things. Just basic things there.
Yep. Yeah, when a patient comes in the room, I've already looked at the H&P, so I know if they've had any previous episodes with anesthesia and what those are. And I'm speaking to the novice here, or maybe the student or the lay person here. But if you read in the chart, it says PONV, that's postoperative nausea and vomiting. So that's something to keep in mind, especially during emergence or even when they go to sleep, because I'm sure you've seen it. Some people have seen it, and just the act alone of getting the preoperative medications can make the patient sick and they can vomit. And that's what we don't want, because we don't want them aspirating any of that bile or stomach acid, because that can just wreak havoc in their lungs. So a lot of times they get preoperative medications for a reason, because it increases their pain threshold and it lowers their anxiety. So yeah, that's basically, so when they come in, I introduce myself, I make sure they're warm, we get them on anesthesia. But once anesthesia starts, I'm focused on that. A lot of times you'll see anesthesia will bring up their laryngoscope after they give their induction medicines. They'll bring up their laryngoscope and set it on the patient's chest. They'll set their whatever airway device they're using on the patient's chest, whether it's an LMA or a endotracheal tube. And then that's my cue. So they'll start bagging the patient. They'll make sure they have a good airway before they give them the paralytic, because they don't want to lose the airway. So then after they give the paralytic and the patient's adequately relaxed, they can tell that by, typically you see them brush the eyelashes. And if they don't have a response to that, that's usually that they're deep enough to induce general anesthesia. And that always depends. Is the patient a drinker? Are they a drug addict? All that's going to affect how much medication they give and how ready they are for intubation. So when they do that, then you'll see them take the mask off and put it to the side or hang their anesthesia circuit on something. And then they will scissor the mouth open, put their laryngoscope in, and then lift up on the laryngoscope, and they'll look at the airway, which they grade, I think, 1, 2, and 3. So a grade 1 view is the best. You can see the cords, you can see everything, and then 2 is not as good, and 3 is worse. If they have a straight shot, they'll stick the endotracheal tube right in, and most endotracheal tubes with most anesthetists, they like to have a stylet in it, which is a bendable wire that stiffens the endotracheal tube so it doesn't bend, it doesn't catch on tissue and bend. So what they'll do is they'll ask you, once they go through the cords, when they see it go through the cords, they'll ask you to remove the stylet. What I always ask is all the way, because sometimes they only want you to pull it back just a touch so they can get it past there, and then pull it away and then hold on to the endotracheal tube where they place it. And then it's Usually you'll get into your own routine. I like to hook the circuit up right away, but I don't like to inflate the cuff. I like the anesthetist or the anesthesiologist, who's also oftentimes right there. I let them do that because you can overinflate it and it can cause an issue. So typically I let them do it, and then I hold it and hold the tube in place until they secure it. One thing they do when they get the tube in place is they want to make sure it's in the lungs. And the best way to ensure that it's in the lungs is with end-tidal CO2. So I look at the monitor, I ask them, I don't throw anything away, I don't take the stylet away, I don't do anything until I know they have end-tidal CO2 and the cuff is up. Once we have that, we're good to go. A lot of providers, you'll see what they'll do is once the tube is in and they hook up the circuit and they see fogging in the tube, they think they're in the airway, which 9 times out of 10 they are. But I've also seen it being in paramedic school. If you get it in the esophagus and there's been air or CO2 or whatever in the belly and they burp or whatever, they let that air out, it will also fog the tube. So the gold standard is end-tidal CO2, and it should be between 35 and 45. Could be higher, maybe if they've been apneic for a minute, and it could be less, but that's around the general range you want to see. And you'll see the waveform on the monitor. So once I see that, I get rid of the stylet. They tape the tube. They do what they have to do. Give them little pointers on if we're working on the right side or left side, so they want to tape the tube on the opposite side. That's important if you're doing a shoulder operation or something. So, and there's so many nuances to this, but those things you always want to be aware of. And then that's when usually the provider will ask you, what position are we going to be in? Are the arms going to be tucked or not? Because that affects what Kelly just mentioned. So, and then we do all the things we need to do, put on the bear hugger, do all that, and then up comes the emergence time. And the same thing. I'm usually done closing, patient's undraped, dressing is on. I'm there for the extubation. And that is the most critical time now, because if they laryngospasm at that time, it can be an airway emergency. So that's why everything needs to be quiet and done in a systematic way. So once they extubate the patient and breathe for the patient, everything's fine. Then I go about my way and do the other stuff I need to do for the patient. But if not, then you need to be there and handle those emergencies, whether it's getting the glide scope or getting this or getting that. A lot of times they'll have an LMA ready because it's good emergency airway. Well, one thing I forgot to mention about intubation, if they have a hard time seeing the airway or it's an anterior airway, they'll use what's called a gum bougie, which is a long, I don't know, I think it's almost 3 feet long. It's like 36 inches long, I think. It's a long blue bendable stylet basically, but it's really soft and it bends. And what they will do is they will use their laryngoscope and they will pass that into the trachea. When you can't see it, you know you're in the trachea because when they move it back and forth, they can feel it clicking against the tracheal rings. And if you see that happen, if you say, I need a bougie or get a bougie, and they'll give you the bougie if you're standing there, you want to make sure it's bent up and you want to take the stylet out of the endotracheal tube because you're going to put the endotracheal tube over that gum bougie. So once they get in and they're confirmed that they're in, you take the endotracheal tube, you slide it down right until they can grab it, and then you kind of hold on to the very top of the bougie, and then they will pass it into the airway, and then they'll remove the bougie. And I don't get rid of it right away until they're confirmed that they're in the airway. And then getting back to emergence, if they have a stridor, then I'm thinking, is this a laryngospasm? And then you can break it. Can they break it by positive pressure ventilation, or do you need to reintubate? If they need to reintubate, you might need to get the glide scope, or if they have the CMAC, which is a handheld video laryngoscope, you can use that. And that's pretty much what's in the back of my mind when I'm putting a patient to sleep. Also on induction, depending on their cardiovascular status, is this the time they're going to code? So, and the longer it takes them to intubate the patient and the more bradycardic they get and the lower their oxygen level gets, that gets scary because they can code at any time then too. So you want to be careful about that. But a lot of providers will use an emergency air duct airway in the meantime. So that's just kind of what I'm thinking and doing when a patient's going to sleep and waking up. So
Perfect, John. Been more perfect. And I know everybody's thinking how smooth I am that I just let you take that away and do such a great job with it, because I am obviously when I'm in the moment, I
do it
these
back and
things.
forth.
I do exactly all the steps. I do it. I know what to do, but when it comes to articulating all those steps, and you just did it perfectly. I struggle with that, but you just went through all those steps so perfectly. And I'm so glad you brought up the bougie, because the first time an anesthesia provider handed me that thing and thought that I knew what I was doing with it, I didn't know you had to take the stylet out of the tube. And I was like, what do you want me to do with this? So guys, listen, if one person can say, oh, that's what you do with it, take the stylet out of the tube gently, and and that tube will just slide right over that bougie, and then you hand it to them. And then, you have to reach way up to pull it out, just like you would the stylet when they're in. But I'm so glad you brought that up, John. I didn't even have that in my notes. I mean, thank you for doing that.
Yeah.
But
I was thinking
Yes,
about
so
that.
he just went through that perfectly. So if you just have to listen to that segment of the podcast over and over, you know who the brains are here now. So you've got it
Not
straight from
me,
the
but
brainy there. No, you articulated that perfectly, and I appreciate you doing that. We're not going to talk about we are not going to talk about malignant hypothermia. Guys, if you don't know, if you work at a hospital, if you're a scrub tech, if you work at a hospital and you don't know what malignant hypothermia is, you're not doing the same CEUs and computer modules on it that I have to
right.
do and that we have to,
You have
talk
to,
about this.
and they drill
Young
on it all the
males,
time.
young males are going to be at
Mm-hmm.
higher risk of this, and obviously that family history, it is a genetic
Mm-hmm.
trait that causes this. Just do your own research on that, and we trust that your hospital has trained you to know where that malignant hypothermia card is. I think that's one of the most important things we can talk about, and what your step.
Mm-hmm.
I think the most important thing to know about MH, as John has said it more than once here, is to go through the scenario in your mind. Sometimes go through it in your
Mm-hmm.
mind and visualize what you would do in that situation, as well as encourage your department, if you're not having those MH drills at least once a year, encourage your educator and your managers to have that drill with you as a team so that you know what to do in that situation, because that is a true
Yep.
emergency that needs to be dealt with
Yep.
immediately.
And just remember, the first indicator of MH is not temperature; it's increased CO2.
Correct.
So,
That's yeah.
I
That's
mean,
on
there's a lot
one
of
those
things we
tests
could
that
have
we have to
included in
take.
this. A lot of things we left out.
Yeah.
Yeah. I
But
mean, we didn't talk
again,
about the
we're trying to
Durant
hit the high
maneuver or
spots.
anything, but
Yeah. We are
yeah,
trying to hit the high spots
we
here
can
and what
flesh
you
that
need to
out in
know.
other podcasts.
And we just dropped our
But if this,
resources for the FA. So get into some of those resources
yep.
that we've encouraged you to have, and read,
Mm-hmm.
and
Yep.
listen to podcasts and read, and we just mainly want to encourage you to have this knowledge yourself, and we've hit on some of the high spots. We thank you for listening to us, and we really hope we've gotten some really good positive feedback. Again, I'll say that on these podcasts, and it just makes us so happy if one person
Yes. Thank
says,
you very
I
much.
learned something
Mm-hmm.
by listening to your podcast. I learned something, and we're finding them
Mm-hmm.
informative and relevant. That's what we want to be bringing to you. And we always welcome critique and ideas for subject content and whatnot. So we appreciate you listening, as usual.
Definitely. Yes. Thank you very much. And one thing I'd like to say is, if there's any prospective students out there that are surgical technicians, and set up early, make sure you're ready, but just watch what goes on in anesthesia. Watch what we all do. And that's the best way I learn by watching. I pick up a lot, and then I learn by doing. But the most important thing I can tell you is game it out in your head. Because if you've read The House of God, Fat Man's Law number 3 is the first thing you do at any code is take your own pulse.
Mm-hmm.
So you don't want to go on vapor lock. But we really
That's
do
a good book.
appreciate all the wonderful comments. And if you have any suggestions at all, please leave them. Something you want to hear, a topic, something. So
Yep.
anyways, we'll give you a report from the conference, and we'll do a conference highlight, probably podcast with pictures and stuff. And we look forward to seeing you on the next podcast. Thank you very much.
Yeah. Bye, everybody. Thanks for listening today. We invite you to like and subscribe to this channel, and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast, or email us at thesurgicalassistantpodcast@gmail.com. Until next time. Content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient-specific information is shared. All HIPAA guidelines will be adhered to.